Good afternoon, everyone. Welcome to today's Indians session. Today is the seventh session of geriatric psychiatry. Today we have with us two distinguished speakers, Dr. Keshav Kumar, who is professor and consultant of neuropsychology and cognitive neurosciences here at NIMHANS. We also have Professor Santosh Loganathan, who is a consultant in geriatric psychiatry here at NIMHANS. They would be speaking on cognitive training and cognitive stimulation in dementia and caregiver intervention in dementia. We welcome you both, sir.
Thank you. Chetan, can I start?
Yes, we'll hand over the stage to Dr. Keshav Kumar. Sir, you can go ahead.
Thank you, Chetan. I'll be talking on cognitive training and cognitive stimulation in dementia. As we all know, aging refers to an inevitable change in physiological, psychological, social, and occupational functioning in an organism over a period of time. Neuroimaging studies suggest that brain reaches maximum volume by adolescence and steadily declines from early to middle adulthood. But the decline is not uniform. Some functions decline quite early, while some other functions decline quite late. So what you see here on the graph on the left side is fluid intelligence, which peaks up by around 23 years and starts declining after that. Fluid intelligence is the ability for abstract reasoning and thinking, while the crystallized intelligence is the knowledge that we have gained over a period of time, information about the world and the other issues that we have learned over a period of time. That peaks by 36 and drops only by 71 years of age. But there's an accelerated decline in cognition overall generally after 55 years of age. So since the cognitive decline doesn't happen, there's an individual difference in the way the cognitive deficits occur, and this individual difference is referred to as cognitive reserve. Cognitive reserve is the ability of the brain to cope with pathology by using compensatory mechanism. Individuals with higher cognitive reserve would cope better with the same amount of pathology than individuals with lower cognitive reserve, even if the brain size is the same. So there are many factors which contribute to cognitive reserve, which is the resilience of the brain. Premorbid level of occupational functioning, if the individual is involved in high level occupational functioning, that also adds to the cognitive reserve. High level of intellectual functioning, higher education, physical activity, social functioning, and of course, cognitive retraining as well. The dictum of use it or lose it is very important when we talk about cognitive function. It has been theorized that change in everyday experience and activity may result in disuse and consequently reducing cognitive processes and skills. For example, if somebody who is very high functioning retires and starts leading a sedentary life, the chances of his or her cognitive function diminishing is quite high. Therefore, it is essential to keep the brain functions stimulated, just like physical activity. So when you look at the continuum of normal aging to dementia, normal aging is caused by microstructural changes. People experience subtle cognitive decline in attention, memory, speed of processing, and executive function. Typically, some of them experience or perform one standard deviation below the mean on standardized neuropsychological test, and there's no disease of the central nervous system. MCI is an interface between normal aging and dementia. Some of them may have behavioral and psychological symptoms of dementia. There are two types of MCI, that is amnestic MCI and non-amnestic MCI. Amnestic MCI patients have difficulty with memory, while the non-amnestic have with executive dysfunction. But some of the amnestic MCI may have other cognitive deficits as well, and which has been changing in the recent studies. To make a diagnosis of MCI, they need to perform 1.5 standard deviation below the mean on a standardized neuropsychological test on one or more domains. There is pathology evident in entorhinal cortex, intraparietal, inferior parietal lobes, and amygdala. Entorhinal cortex is an important area of memory circuitry where information processed by the frontal lobe is stored in the entorhinal cortex for a short while, where it compiles the contextual cues and the content and the information is transmitted to the hippocampus to subiculum. So it becomes a very important region for memory losses. So coming to dementia per se, behavioral and psychological symptoms are evident in dementia. They perform the performance falls below 2 standard deviation from the mean on a standard neuropsychological test. There is pathology in multiple regions, therefore the presentation and the cognitive deficits also can be quite large. There is an interplay between cognitive deficits as well as behavioral and psychological symptoms. When the patient experiences cognitive deficits, there's a reduced ability to cope with the environmental demand, resulting in anxiety and depression as well as aggression in some of the patients in the early stages. Therefore, improving cognitive functions in individuals in the prodromal as well as early dementia could potentially improve overall well-being. Coming to neuropsychological rehabilitation is an application of neuropsychology and cognitive neuroscience to improve cognitive functions in acquired brain damage or psychiatric conditions. Cognitive retraining, cognitive training, cognitive stimulation, all these are used interchangeably in many studies. So when we look at the entire gamut of cognitive stimulation, it's all put under the umbrella of cognitive-oriented treatments. So as the disease progresses, there's severity increases, there is symptomatology change, as well as the cognitive deficits worsen over a period of time from healthy normal aging to MCI to mild dementia and to moderate dementia. So cognitive retraining and cognitive stimulation, cognitive reminiscence therapy also would change according to the severity. Cognitive training is more to restore function. It is standardized task to promote plasticity in certain regions of the brain and to bring about changes in the cognitive function. While cognitive stimulation is more less intense and more to maintain the cognitive functions, and reminiscence therapy is to kind of stimulate and keep the mind agile to the extent possible. So cognitive-oriented treatment is an umbrella term referring to a group of non-pharmacological intervention with specific focus on improving and maintaining cognitive processes and its impact on functional ability in daily life. There are a number of studies on cognitive intervention in healthy normals, MCI, and dementia. So some of the meta-analysis of studies show that the computer-based cognitive intervention program improves cognitive function in older people with MCI. However, the long-term transfer of these improvements and the potential to reduce dementia prevalence remains largely unknown. Now, this is one of the largest studies on healthy normal individuals, known as Advanced Cognitive Training for Independent and Vital Elderly, known as ACTIVE. The sample consisted of 2,832 people recruited from 1998 to 2001, age ranged from 65 to 94 years, recruited from the community, clinics, and hospital. They underwent a 10-session group training. They were trained in 3 different distinct cognitive interventions. One was memory, speed of processing, and reasoning. So memory training typically targets verbal episodic memory. Participants were taught to use mnemonic strategies for remembering word list, sequences of items, text material, and main ideas and details and gists of the story. Participants were trained how to organize word list into meaningful categories and visualize the meaning into images and make mental associations to recall the words and the text. Exercise involved recalling list of nouns, paragraphs, shopping list, lists of prescription labels. So this is the typical technique used across conditions and across severity. Even in very many schizophrenia studies and TBI, you find this as a mainstay of cognitive retraining for memory functions. So reasoning training focused on ability to solve problems that follow a serial pattern. For example, identifying patterns in a letter or number series or understanding patterns in everyday activities such as travel schedule was encouraged. These could be both individual sessions or group activity. So coming to speed of processing, which focuses on visual search skills and ability to identify and locate visual information quickly on a screen. And distractors could be added to increase the complexity of the task. Difficulty was manipulated by decreasing the duration of the stimuli, that is the exposure, adding either visual or auditory distractors to make the focus more difficult, increasing the number of tasks to be performed, that is, simultaneously they are engaged in two or more tasks, which becomes divided attention paradigms, or the stimulus is presented on a larger or wider expanse or area of the screen, so the search becomes more difficult. Difficulty is increased each time they achieve the criterion performance. So most often the criterion performance is about 80 to 90% of correct responses over 2 or 3 sessions. Then they go to the next level. So these patients from active study were followed up after 11 months. 60% of them were randomly selected, and 75 they underwent a booster session for 75 sessions for a 75-minute session for 2 or 3 week period. They found significant improvement on trained tasks. However, there was no evidence of transfer of training to everyday functioning after 2 years. So this transfer of training has been a big issue in cognitive retraining. Transfer from trained task to untrained domain may depend on the nature of the task and the way the tasks are designed. So this transfer is known as near transfer and far transfer, and also transfer to everyday activity. So habit is one of the most important study which has looked at very intensive cognitive training. Habit is a unique multimodal behavioral intervention offered by Mayo Clinic. It is a 5 hour per day, 5 day per week, 2 week program for individuals with MCI. The 5 1 hour components include daily physical activity, that's 1 hour of physical activity, computer-based cognitive exercises, patient and family education, separate support group for MCI and partners, memory support system and compensation training, probably encouraging external use of external memory aids, memory diaries and notebooks, and such kind of external memory aids. There are a number of commercial cognitive training programs, and cognitive training is a $1 billion industry. And the first training program that came into the market was by Dr. Kawashima, The Age of Your Brain, which used a Nintendo console with the screens on two sides. On one side of the screen, a question was presented, and the other side of the screen, which is a touch screen, the patient was required to write the answer as rapidly as possible. This is another activity from the same game, which says, oh, look, a party. People are about to enter and exit this house. People will go in and out, count those inside the house, which means the patient has to remember who came out, how many have come out, and how many are inside the house. Requires a multiple component, and none of the cognitive domain is a unitary in nature. They're all overlapping. So as the cognitive load increases, there's very many other cognitive functions that gets engaged, and multiple networks get engaged to mediate the cognitive load. So on this task, the idea is to do it as quickly as possible and reduce the age of the brain. So this is a typical example of how a test can be converted into gamification of test. I'm just using this example to explain that. So there is a typical psychological paradigm known as NBAC test, where the patient has to respond to a target one before the one presented now. So that is converted into a game where the frog has to jump on a leaf that gets highlighted. One before that, it will be the target, or two before that if it's an back to paradigm. So what are the issues in cognitive retraining? These issues are relevant for cognitive retraining across conditions and across domains. So there's no agreed upon theory for cognitive retraining. No guidelines on how to develop cognitive tasks, what domains to train, and how to train, how many sessions, for how long. So that's the dose and the intensity of the session. How to increase the levels of difficulty. Are the changes associated with training retained or enduring over a period of time? Is there near and far training? That is, the task trained will transfer to the untrained task. And generalization. So whatever change that is seen on the pre and post test, will that generalize to everyday life? If there's no generalization to everyday life, probably the cognitive retraining is not effective. So these are the typical issues that people in the field of cognitive retraining face. So coming to Reminiscence experience, for the last 30 years, neuropsychology unit at Reminiscence has been developing theoretically based cognitive training program. The challenge for India is to develop simple tasks with simple material that's available in every Indian home, which is time and cost effective programs to cater to all strata of the society. The programs can be both hospital-based as well as home-based programs. So this is a model that we have developed for the last 30 years, and we started our work with TBI, then stroke and other neurological condition, and moved on to psychiatric condition like schizophrenia, depression, dementia, epilepsy. So what we developed was all conditions, the primary cognitive dysfunctions are in the domains of attention, speed of processing, executive function, and memory. And we realized that training attention and executive functions will actually transfer, in addition to encoding, would enhance overall cognitive functions and symptom reduction that we saw in head injury patients with 30 sessions of training. And we moved on and we titled the training program over 30 years. And currently we're using an 18-session program for dementia, MCIs, and other psychiatric conditions. So the changes in cognitive functions and the symptom reduction will facilitate generalization and return to employment. So if there's a change in the cognition and mastery over task, and this task should be accommodated in the brain, probably in terms of plasticity, therefore bringing about neural plasticity. So the rationale for rehabilitation, is the notion that practice on carefully selected tasks promote recovery of the disrupted circuitry and restore functions in the impaired cognitive processes themselves. The tasks mediated by the circuitry are then performed in a way similar to non-brain damaged individuals. There's a lot of literature to support this. So the mechanism of recovery is plasticity, which is a buzzword in cognitive retraining. There are two. Plasticity refers to the intrinsic capacity of the brain to respond to internal or external stimuli or demands. There are two kinds of plasticity. One is spontaneous recovery, one is experience-dependent recovery, and most rehab professionals work more on the experience-dependent recovery. So from our experience with the several conditions, we developed a cognitive training program for dementia, which was a DST funded project. We developed 8 domains of cognitive retraining uh, uh, with 8 levels of difficulty. So domains were working memory, short-term verbal and visual memory, and verbal memory, and memory for stories, response animation and activity, and as well as reasoning. So we took this program, which is a paper pencil program, for 30 days to the community as well as clinical sample. So our staff went to the community and contacted patients from welfare association and gave cognitive retraining on a daily basis for 1 hour. So what we found was, after the intervention, the time taken on attention task significantly reduced. The omissions and commissions also reduced significantly. On digispan and spatial span forward conditions, the overall performance increased significantly. We also found changes in executive function, that is working memory, both visual, verbal, as well as visual spatial working memory, as well as fluency. So you can see the changes on the pre-post on fluency as well as working memory task. So another major problem in elderly is the memory. So we saw improvement after intervention on acquisition of information across trials on word list and logical passage, as well as visual learning and memory, immediate and delayed recall scores. So simultaneously, we conducted cognitive training on patient population with 6 MCIs, 6 mild Alzheimer's, 2 patients with the Parkinson's, 1 patient with the FTD. Similar to the healthy normals, patients also showed decreased time, commissions, omissions on attention tasks. Digispan forward did not improve, but digispan spatial span forward did improve significantly. Executive functions also improved. The fluency task, both fruit, animals, and vegetables improved significantly. Working memory showed small changes. Visual spatial skills, there was a significant change. The most important thing was the improvement was seen on both verbal and visual learning and memory tasks. With IR and DR, the DR, delayed recall, improved very significantly. So the training was not restricted only to cognitive test. We also found the transfer of these changes on all the scores, on the scales. So GHQ neurological screening, 88 easy, the test of everyday functioning, and neuropsychiatry inventory, as well as clinical dementia rating scale, and geriatric depression scores, all of them came down with intervention on the post assessment, suggesting that there was a generalization from the cognitive task to multiple domains as well as on the outcome measures. So we digitized the entire cognitive program, and Adobe came forward to digitize this program for us, and we administered this on 7 elderly, normal elderly, aged between 55 to 80 years, 18 sessions, each session lasting for 30 minutes. Results showed that there's a significant improvement in attention, speed of processing, total learning on word list, delayed recall and story test, as well as visual learning and memory, even in healthy normals on the app. So these are snapshots of screenshots of the domains that we have done. This is visual memory, this is verbal memory, this is response inhibition, this is working memory. So the tasks are constructed in such a way that even severe patients should be able to do the first level, and healthy, normal, high functioning patient should be able to struggle on the task and find it difficult. So we have a range of activities in this app which can cater to the entire spectrum of healthy, normal aging to dementia and patients with severe cognitive deficits. So this is the graph to represent the pre-post change. The red bars are the post and the blue bars are the pre. We saw changes across a number of domains of cognitive functions. This is another graph showing improvement on many neuropsychological tests. So coming to cognitive stimulation therapy. Cognitive stimulation therapy is a milder form of cognitive retraining. It is one of the non-pharmacological intervention for people with dementia, including a range. It includes a range of fun activities to improve cognitive function in patients with dementia. The primary aim of this intervention is to improve thinking, concentration, memory in a group setting. Cognitive stimulation activities are not aimed at systematic improvement of particular cognitive domain, unlike cognitive retraining, considered as stimulating and generally good for the brain. So typical cognitive stimulation therapy is 14-session intervention twice a week, lasting for about 45 minutes to 1 hour. There could be some physical activity or exercise in some of the programs. It's a group activity with 5 to 8 people in the group. The number of groups, the members of the groups are generally identical in terms of severity of illness as well as level of cognitive functioning. The session could include the following activities. There'll be an introduction session where they have to introduce themselves or call people by name. Every individual may have a name tag to facilitate remembering the name. There'll be a group song that is decided by the group and selected by the group, which they have to sing. There'll be a small brief discussion on current affair, and there'll be main activities. The main activities will be discussion on a range of topics, including past, present events, topics of interest, current styles, fashion, word games, puzzles, movies. There'll be practical activities such as cooking, baking for about 45 minutes to 1 hour. Patients with more impairment, CST will focus more on the reality orientation therapy, kind of, trying to get them to name days of the week, time and place. So this is one typical activity where they will be given a ball with the activities printed on them, and they can choose one activity and start talking about a particular topic. So systematic reviews show minimal changes in ADLs, social functioning, and quality of life. But meta-analysis reveals inconsistent results with regard to quality of life. Coming to the last form of therapy is the reminiscence therapy. Development of reminiscence therapy can be traced to Butler, 1963, in which individual looked back at the past experience, unresolved difficulty and conflicts. RT involves discussion about patients' past activities, events, and experience using external aids such as photographs, video clips, household items from the past. Pickwatt did a review of 100 studies, and he classified reminiscence therapy into 3 types. Simple reminiscence, where the individual recalls selected personal stories of her life. Life review, this type is more structured and evaluative process. Usually, individual therapy is covering the whole life in a chronological order. Here, the focus is to integrate both positive and negative memories as the patient elaborates them. The third one is life review therapy. This therapy is primarily used for individuals with depression, depressed mood, and other mental difficulties. Aim is to regulate, re-evaluate negative memories and promote positive view of life. Emphasis is to develop a narrative biography integrating past, present, and future. These effects of RT are comparable to medication as well as other psychosocial intervention with this group. To conclude, cognitive retraining program improves cognitive function in normals, MCI, as well as individuals with dementia. With the progression of severity of dementia, cognitive stimulation and reminiscence therapies are useful in improving cognitive function and quality of life and keep the brain agile to the extent possible. However, there's a need for better intervention methods to improve quality of life and independent living, and the interventions should be looked at more in theoretical underpinnings. Thank you very much.
Thank you very much for the wonderful presentation, sir.
Thank you, Chetan.
Now, we'll go to the next part of the presentation by Dr. Santosh Loganathan. Santosh, sir.
Can you hear me, Chetan?
Yes, sir. You can go ahead.
Okay, great. Okay, I'll just share my screen now. Are you able to see my screen, Chetan?
It is starting, sir. It may take a while.
Okay, okay. It says screen sharing is paused. Is there a problem there?
Sir, can you reshare it, sir? Because we are not able to see the screen yet.
Okay, let me stop it and then reshare it.
It stopped sharing again.
Stop sharing again. Okay, just wait. Okay, can you see now?
It has started now.
Okay, great.
It may take some time. Yeah, it has come up now.
Okay, so good evening to all of you.
Can you make it full screen?
Sorry?
Can you make the slide? Now it has come.
Yeah, it's in full screen now. Okay. Yeah, good evening to all of you. So I'll be talking about the caregiver interventions for dementia. As you all know, caregivers are, an important part of the treatment process itself. A lot of times we are talking about, the individual or the person who has dementia, but the caregiver actually goes through a lot of um, unseen events that we as clinicians must know and must realize and recognize to understand what they are going through. So to understand what is actually the meaning of the word caregiver, you all should know that the caregiver could be a family caregiver or an informal caregiver. The informal caregiver is somebody who's an unpaid family member. Basically, they're not being paid for any of their work, or they could be any of a family or a friend or a neighbor who provides care. And the care could vary from various activities like, bathing, dressing, giving medications, to tube feeding, and ventilator care. I mean, these might seem very simple, but one must remember that bathing is not just giving a bath, but giving a bath to somebody who is refusing to take a bath. It becomes more challenging. Or maybe giving a list of multiple medications to someone who is demented, and so there might be some inhalers, some injections, some crushed medications, and so on and so forth, and watching for side effects makes again the job description quite challenging. Chetan, I'm not able to see the full screen here. There are a list of pictures on the right side. Okay, yeah, I got it. Okay, so around 44 million caregivers over the age of 18 is the current estimate around the world. This is for any chronic disease. And in terms of older adults, nearly 2/3 of older adults who actually need help are not getting it from the formal sources. That leaves the informal sources or the family caregivers to take up this particular role. And in terms of the older adults, if you look at the numbers, age 65 and older, there is a steady rise from 6.4% in the previous year to almost 8.4% by the year 2030, which means that the number of the elderly, this numbers, I'm sure that you would have all heard it in the last few presentations that have been going on, in terms of how the prevalence of dementia is progressively increasing. And in India also, the estimate is that by the year 2030, the numbers would actually double from 4.4 million, which was the estimate in 2015. So all this adds to a lot of social and economic demand on individuals and families caring for, the people who have dementia. Now, coming to the Indian socio-cultural context, you all need to understand that in India, the caregiving is pretty much rooted in, the traditional extended family system. Cultural beliefs like the kinship obligation and respect for elders and parents is something that is deep rooted in our society in the extended family system. So people have this sense of duty and obligation, or maybe they're doing it because nobody else is there to do it. They just have to do it because there's no other way. And there is nobody who assigns that this is to be done by so and so. It's just that one person assumes all particular aspects of caregiving. And the moment it comes to dementia, caregiving becomes even more complex and even more intensive. And people are somehow left helpless, and they really kind of struggle with it for most of the time. So if you look at the caregivers in India, pretty much they are women. It might be daughters, daughter-in-laws, or wives of somebody who has a dementia. And they are, I mean, I'm not saying that men don't care. It's just that vast majority are women. And in India, there is this concept of what is known as offering seva or service or worship. It's almost like offering divine worship to the elderly. The elderly is seen like almost one of, in terms of the power structure in the family, the elder person holds the highest amount of respect. So taking physical care of the frail elder could be, applying oil and braiding the hair and changing the clothes and so on. And in a way, this also reveals power, that the aging body is now in the process of weakening. So how do people understand dementia? So most people in India, it is seen that they view dementia as a part of normal aging. He's just forgetting things. So that's part of his age. He's supposed to be forgetting at this age. So as a result, what happens is that people are not able to recognize it. There are low expectations from the older adults as well. And this high tolerance to the disability also leads to a lower recognition of dementia among people. They might attribute it to him being a difficult personality. He was always a difficult personality all through his life, so he's behaving like that now. Or they might not be open minded enough to accept other medical explanations. And there is also an attribution that the family is not caring much for this person. That is why this person is probably behaving like this. So there are many such attributions. And they might also put the blame back on the person. He's not putting enough effort himself or herself, and that is why this person is behaving like this. So various attributions, kind of mask the recognition of dementia in our society. And in addition, in the healthcare system itself, there is a lack of mental health infrastructure and the scarcity of other resources and residential care and community systems. As a result, it becomes difficult for people to actually seek help also. And they generally receive very little support for their work of caring for people with dementia. And as a result, this activity becomes progressively more demanding and stressful and frustrating, and a lot of caregivers experience tremendous stress. I must say that there are a set of people who do experience a lot of satisfaction also, in terms of the pride that they have in caring for the elder person, in terms of the meaning of life that they realize for caregiving. In spite of all of these difficulties, many caregivers do choose to provide this care till the very end. So, what are the kind of challenges that the families go through in India in changing times? So, if you look at the traditional family structure, again, a lot is changing now. We're no longer the big Indian family with the extended family. We are progressing to much more nuclear family systems. And as a result, what is happening? There is a breakdown of the support system. You don't have the rest of the family members providing the extended social support. As a result, you are probably dealing with a single family probably providing support, and that becomes all the more stressful for that particular family and that particular individual. So this change in the traditional family structure is something that is happening, and India is in that process of change, very similar to what is happening in the West. We are still not yet there as in the West, but we are in that process. And also the change in the traditional gender role of caregiving. I talked to you about how the women have been the predominant caregivers in India. But over a period of time, we are again in that process of change, where we are seeing more and more women who are in the workforce, and they are not actually being able to be available at home for the role of caregiving. And as a result, there are more men also coming into this role of caregiving now. So there are changes in this gender role that is also happening in our country. And more importantly, I think most caregivers in India are still unprepared. Unprepared because they are just thrust into the role. They just happen to be there. Nobody else is doing it, so they happen to do it. And they have no idea about how to go about it, lack of information about what is actually happening. All of this makes them very unprepared. And in terms of the hidden costs, I think that there is also a possibility of people losing their job and their salary and income. That is something that can indirectly, apart from the direct costs like medicines and hospitalization and diapers and so on, these indirect costs are something that really play a huge role in terms of caregiving. And as a result, most people are unable to take care on one side, and also balance their work life. So this entire balancing act becomes an issue of balancing the work life and their personal life, and the caregiving role, which can get them into a very difficult position. And as a result, people, they put in so much of effort. Many people can become extremely skillful and they can actually master the role of caregiving, but there is a lot of lack of recognition of this, and as a result, people tend to exclude them. They themselves become lonely, and the stigma of being a caregiver for somebody who has dementia is something that is also starts becoming an issue for them. So there is a need for information, and in terms of training caregivers, a lot of input needs to go in for these caregivers to understand what it is to be a caregiver for dementia. What is this person going through? And where can I go and seek help in terms of hospitalization or medication or seeing a doctor or seeing any other rehabilitative services? So there's a lot of need for information that is still lacking in our country. So coming to the basic interventions for the caregivers, I have just simplified it into these four broad components. You can look at this article for more information, but most of the interventions can fall into these four broad components. And this particular article is actually a compilation of most of the evidence base that is available in terms of interventions for caregivers of dementia. So primarily it is the psychoeducation, which is, I think, can be offered in multiple ways. You can offer psychoeducation in a form of a group format, and you can offer psychoeducation in the form of a one-to-one session, or you can offer psychoeducation even in online mode now. So things have really kind of improved as far as psychoeducation is concerned. And psychoeducation is something that can even be offered by a non-skilled person, as in you don't have to have a training for psychoeducation. It can be done by even non-skilled person who has some knowledge about dementia. So it basically offers information about dementia, about the causes, about the treatment available, and so on. The basic information about dementia. The second is in terms of counseling and psychotherapy. And this is predominantly for the caregivers who are under a lot of stress as a result of their caregiving role. And sometimes people might also be slipping into loneliness and depression. And for them, the counseling and psychotherapy, cognitive behavioral therapy is something that is found to be useful. And psychotherapy is predominantly for the caregivers who are undergoing a lot of stress and depression. The third is the multi-component interventions, which, as the name suggests, has multiple components in it in terms of not just providing psychoeducation, information about dementia. It also gives interventions towards counseling them and taking care of themselves, as also providing the problem-solving skills, the coping skills, and other necessary skills that are required for managing a person at home in terms of maybe their activities at home, in terms of how to manage their behaviors, difficult behaviors, and so on. So it is a very integrated intervention that encompasses all aspects of caregiving, not just one aspect like psychoeducation and so on. So it is a whole package that is there, and nowadays these packages are becoming available online as well. The fourth one is in terms of the mindfulness-based interventions, which make the caregivers focus on the here and now, and gets them to slow down in their lives and gets them to look at one thing at a time. And this is something that again is found useful. And so are other interventions like yoga and breathing exercises also are something that are now picking up and have been found to be useful for caregivers in terms of reducing their burden, stress, and their quality of life. Now, what are the kind of aspects that caregivers are looking for when they come to, let's say, the clinic? Often we are predominantly involved as clinicians, maybe to look at the person with dementia or his behavior or her symptoms and her sleep and so on. But a lot of times we fail to, or we might not really focus on what the caregivers need. They might be asking us things, but if we are not equipped ourselves as clinicians to guide them, then it might be difficult for them to really provide the necessary care at home. So there are lots of booklets and lots of information that is available. And I would suggest this very useful booklet for caregivers. It's from the Alzheimer's Disease International booklet for caregivers. It's a very simple booklet which every clinician must go through to understand some of these nuances that that are involved. I mean, that's gives you very basic information. There are very I mean, there are lots of information actually out there in terms of how to look after a person with dementia. In fact, there's a book called 24-hour caring, or 24-hour caregiving, which is an extensive collection of how to go about caring for a person with dementia. So let me just go through about some of the basic things that you need to know as a clinician. So giving basic information about dementia, about the the prognosis, about the treatment, about the causes, and about the medication involved. This is some of the basic information that needs to be given to every caregiver. And in terms of the practical tips on managing dementia, this can be anything to do with looking after the person at home, in terms of having a routine for the person, maybe, or maybe, how this person needs to kind of manage a particular day. Because in this whole confused schedule, if the person has a routine, how this person's routine can actually be a way which can offer some sense of control over a particular day. And so some of these aspects about managing a person are can vary from very simple activities, like maybe their dressing, for example. Uh, you might want to, arrange their clothes in a particular way, and then, ask them to, wear it one by one, because they might not be able to choose a variety of clothes that they need to wear for that day. They might have difficulty in wearing it. So you might have to actually give them some sense of uh, help, but at the same time keep them, or make them to remain independent in trying to manage their activities on their own as much as possible. So various activities, like even their cooking, and if they're able to cook to a certain extent, it's okay, but you might have to also watch out and see if they're not harming themselves by switching on the gas stove and so on. So in things like driving, they might not be able to drive, but you might have to advise them, or to take the help of a doctor to advise them that they might have to stop driving because it might be dangerous for them to drive. So there are a lot of things that have to be managed over a period of time, and it can vary from the severity, from the early stage to the moderate stage to the severe stage. And these tips need to be given to the caregivers as and when the person is moving from one stage to the other, and help them to kind of manage it at each stage. Then there is also personal and emotional stress of caring. So the entire aspect of caregiving can be stressful. So the caregiver needs to also have some time for themselves, some time for themselves in terms of leisure, in terms of for their own space and relaxation, and advise them some breathing exercises or yoga, or time away from caring, which can be very difficult because there's nobody else to offer that care. So this kind of respite care provided by any other family or a friend is something that we need to discuss with them, and how they need to take care of themselves in addition to the role of caregiving. That can be a little challenging because they might not just find the time, because they're all the time caregiving. So getting away from caring itself is something that we have to advise them. Okay. And help for the care basically deals with talking of where they can get help. A lot of times people are totally clueless about where they need to go for treatment, or their services, or in terms of medications, or the doctor, or in terms of the support system, and other rehabilitative services, maybe some respite care, or sometimes when they need to go off somewhere, or when there's an emergency where they need to take this person. All of this information is something that the caregivers also need. And for some of the poorer sections of society, things like disability benefits or even the old age pension, they might not even be availing some of these things. So giving information on all of these things would actually go a long way, because even with just the benefits, they might be able to procure some of these medications that are prescribed for the person with dementia. Now, the reason I put up this is the basic, timeline of disease progression and how the current state of late diagnosis is made in terms of how people present because of the lack of information or the pathways to care, or in terms of the um, um, lack of information and knowledge. They somehow end up coming late, and as a result, the diagnosis is also made late. So the recommendation is basically to make a timely diagnosis, and timely diagnosis basically refers to responding to the patient and carer concerns, as in they might have reached a particular service or the healthcare system at some point, but at some point we might not have picked it up, we might have missed it, or because of certain lack of skills or lack of resources that are available, it might be missed, and as a result the person might be diagnosed late, and that leads to again problems. So early diagnosis is something that is stressed upon, and rather than proactively screening for a lot of cases in the society, the emphasis is on to pick up the cases that are actually coming to the healthcare system. And does the early diagnosis benefit? Yes, definitely to the caregivers in terms of optimizing the medical management. And it gives them basically the understanding of what this person is going through, what has actually happened to this person, what has changed, and gives them the time to make decisions, and gives them the opportunity to access help, that they need to actually seek help for this condition, and it's not just forgetfulness that this person is going through. And it also gives an opportunity to reduce the risks of falls, maybe the risks of going away, wandering away, and so on. So a lot of complications can be avoided, and indeed the family can also plan for the future in terms of maybe his will and so on, in terms of planning for certain decisions that are very important. Maybe this person is a businessman who owns a business, or this person has a lot of property and so on. So a lot of things need to be discussed, and this early diagnosis gives an opportunity for the caregivers and the family members that particular so much of time for them to be prepared for the role of caregiving, to prepare for them to understand and get adapted to this particular change that they are going through. So early diagnosis is definitely beneficial for caregivers, and that is something that we as clinicians need to remember. Now, in terms of the future directions, as far as caregivers are concerned, I think that it's acknowledged now that the information, support, and the skills and the training is required for the caregivers to get them ready for this role, and access to information about the services that are available, not just for the person with dementia, but also for them as caregivers as to how they can take care of themselves. And most of these interventions that we are talking about sometimes tend to also come from high income countries or the Western countries. And we should also remember that we should be culturally sensitive to some of these interventions, because in India things are so complex in terms of the belief systems, not just the belief systems, but also in terms of the interventions. Some of the interventions might talk about very Western concepts of maybe, for example, dressing a person, let's say a lady who has dementia, with maybe very Western clothes, whereas in India, the person might be very comfortable wearing a sari. And then, when we are talking about interventions, we'll have to remember some of these culturally different aspects of caregiving, and then you will have to adapt your interventions to the caregiver accordingly. And also getting the workspace more ready for looking at them to be a little more flexible in enabling the caregivers to go back and take care of their caregiver and at the same time manage their job and have their jobs so that they can manage the work life in a balanced way. And that is something that we might have to look at in terms of talking to the employers and so on. In terms of the community, yes, a lot needs to be done in terms of promoting awareness, and this definitely will improve the understanding and reduce stigma associated with dementia, and also promote the younger generation to also be a very important part of the caregiving and not just leave it to one generation and the other generation just does not seem interested. So there needs to be intergeneration solidarity that is required in families. And yes, future research to support family caregivers is something that I'm going to talk about a little while later. As far as technology is concerned, how the technology has actually invaded now into caregiver interventions. Of course, now with the COVID situation, this is something that we are all doing now. And right now we are having this whole thing in a online platform. Similarly, a lot of the caregiver interventions have been made available online platform. A lot of them have been given earlier on or over the telephone or just over the internet or in terms of e-learning platforms. And all of these have known to reduce caregiver depression, anxiety in terms of their burden, and also enhance the caregiver's self-efficacy and their mastery and quality of life. Now, similar online support program for caregivers was tested in India and several other low and middle income countries, and that was called as iSupport. And basically, this iSupport is a collaboration with the World Health Organization and Stanford University, and was funded by the Alzheimer's Association. And basically, it was a pilot trial to study the effects of an online support program for family caregivers of persons with dementia. Now, what was the component of this study? I just briefly touched you, like I talked to you about the multi-component interventions. This is definitely one of the multi-component intervention because it does have aspects on basic information about dementia and what it means to be a caregiver and what the kind of changes that are going through they will be going through as a caregiver. And in addition to that, there are lessons which talk about um, how they can look after themselves, how they can reduce stress, and how they can actually look after themselves as well while they are having this task of caregiving. In addition, specific to caring for the person, there is providing everyday care in terms of making meals and taking care of their toileting, incontinence, personal care, and how they can actually schedule a particular routine and so on. As is with managing the challenging behaviors like aggression or wandering behavior or delusions and hallucinations and poor judgment and so on. So this has been devised by the collaborating agencies, and these lessons have been put together by a group of experts from the entire globe under the guidance of the World Health Organization. And we actually had, I have a small video that I would like to play. Maybe you can just tell me if you're able to see it now. Okay, maybe I'll just play it as it is here in the screen. It's not playing in the screen. Yeah.
Doesn't matter, Santosh, you may not have time, so might be good to move on with your slides.
Yeah, it's a very short video. It's almost over. Can you see it? Is it playing?
No, it's not playing.
It's not playing, is it?
I mean, you can see some slide, but it's not.
Okay.
Can't hear anything.
You can't hear the music also?
No.
Okay, no problem. I'll go ahead with the slides then. So for those of you who want to know more about this particular study, this is the study protocol is published already and it's available online. And we also have published another study, which is the perspectives on the components, as in what the caregivers actually wanted in this particular program is given in a separate paper. And the pilot RCT is also on the verge of being published, and that will be published very soon. So we did find that it was not easy for caregivers to actually come out and spend a lot of time online. But at the same time, a lot of these interventions, are probably suited for those who are, tech savvy, and the ones who are, comfortable using a computer and English speaking and so on for the urban population. But I guess that this is something that will be the future in terms of how things can evolve with the smartphones being available now in the country, or with almost a large proportion of the population, and a lot of support and a lot of training can be provided through just the phone. And I'm sure that these are things and signs of things to come in the future. In terms of self-help groups, I think that this is something that caregivers do look out for. There are a few that are listed here. Some of them are, predominantly in Bangalore, and some of these are websites that you all can go and look at for more information. And the dementia care notes is something that it's replete with a lot of information and resources and tips. It is actually run by a person who's a caregiver herself, with a lot of stories about how she cared for her own mother and various other caregiver stories, and lots of information about caregiving. And of course, the ARDC, the Alzheimer's and Related Disorders Society of India, it has 14 chapters across the country, and it is an NGO that supports people and families with dementia in India. The Nightingale's Medical Trust, and there are a host of other organizations that care for people with dementia, which I'm sure that will be useful for caregivers to go and actually have a sense of belonging in some way, because they will be able to share their stories and feelings with other caregivers, and that will give them also a sense of being empowered, that they are not alone in this journey, and that there are other people and they could learn from other people as well. Just like how we have self-help or support groups for various other conditions, there are several self-help and support groups as well. That comes to the end of the presentation for today. These are some of the references that you might be interested in. Thank you.
So thank you for the excellent presentation, sir. I think it concludes both the presentations. I think the participants can put their questions in the chat box, or they can also unmute themselves and they can go ahead with question. So currently there is one query in the chat box. I will read out, sir. Here one comment and one query is there. How do you manage the caregiving difficulties like repetitive questioning, wandering, and incontinence, which do not respond to cholinesterase inhibitors? There also a comment like managing frontotemporal dementia is very difficult.
Yeah, so some of these behaviors that you have mentioned are definitely challenging, which cannot be managed by medication, and there's no point just giving a high dose of antipsychotic or something to make them sleep or something. And some of those strategies are a little dangerous also, because antipsychotics, especially some of these antipsychotics given in dementia, there is also an FBI black box warning in terms of how much you can use. So say, for example, wandering is something that is very common and very distressing symptom that people come up with. And it's important to actually have some kind of ID on the person who has dementia, so that in case they get lost, there is always an ID, and that they are carrying an ID with them. So these are some of the simple things that can be done. In terms of incontinence, I guess again, incontinence is you might also look at having a regular visit to the bathroom for this person, rather than wait for this person to come and tell you, because they are not going to do that, or they might have forgotten how to do that. They might have forgotten where is the bathroom, and they might have feed in the living room. So it is important for us to realize that maybe just like how we take a child every few hours to the restroom, we might have to take them to the restroom before they actually reach out to us. So these are some of the things that you might have to do. Repetitive questioning, yes, it again can be an issue in some of the dementias, like say frontotemporal dementia. The repetitive questioning is also part of the repetitive behavior. And maybe in some of those conditions, you might want to maybe consider an SSRI. But repetitive questioning can also be a problem in other dementias or Alzheimer's dementia because of memory issues. And often we might get frustrated, we might get hooked onto them, and we might lash back. So one of the things that you might have to tell caregivers is to not to retaliate back.
Sir, there is a break in your voice. Hello? I think Dr. Santosh sir has faced, I think, a technical glitch. I think his microphone we are not able to hear. Can we? There's one more question to Dr. Keshav sir. Sir, the participant has asked a question. Does NIMHANS Geriatric Department offer online cognitive training and cognitive stimulation for patients from other states? You mean to ask for online if the training is there, services are there?
You've just started the web-based training, which is an interactive one. So cognitive training we've just started, but not the cognitive stimulation. We just need to evolve a method to kind of do it online. But we would like to do it eventually.
Okay. I hope it has answered the participant query. Any more questions? Please unmute yourself and go ahead, or else you can type in the chat box. We will take up your questions. I think there are no queries in YouTube also, sir. No, in the chat box of YouTube also there are no questions. Just I have one query, sir, to Dr. Keshav, sir. The habit model you presented during a presentation, it looks like a multi-model. It has a physical component, it is a cognitive component, it also has family component also is there. How effective was it, sir, in patients with MCI, especially for 2-week intervention it is? So
it is a very intensive program. I think it is effective because it looks at all the aspects. Cognitive retraining also produces quite a bit of change. So does physical exercise, Tai Chi. There are multiple methods of enhancing, and this is a combination of it. So I think it is effective, and the changes also could be lasting.
thank you, sir, for the reply. And Dr. Santosh sir is mentioning about a booklet, a caregiver booklet from Alzheimer's International. Recently, geriatric link services have translated this English version into Kannada version also. With help of our friends in the social work department, we have translated into even Kannada version also. This is for a kind of information. To Dr. Keshav sir, there are another queries are for you. Is there any short-term courses online for clinical psychologists to get better trained in management of dementia? We ask a particular question for a management of dementia or give any specific training.
Not as of now.
This is
But
more of
some of the cognitive training program that we have developed, it is free of cost, and anybody can ask for the program. And if they write to us, we will give you a program that can be downloaded on mobile phones, Android apps. So they can use that instead. Right now, we don't have any program for online program for public.
Thank you, sir.
Yeah.
Yeah, as I told, any request is there, I will happy to share with you the module. I think, sir, I think it is about 4:50 already, sir. Shall we wind up, sir?
Just two things to add, Chetan and Shivshankar.
Yes, sir.
Professor Keshav covered mainly the cognitive therapies.
Yes, sir.
Especially cognitive retraining and simulation and all that. But there's also individual therapy which you can offer for people who are in the early stages of dementia. So you need to remember that supportive therapy, mindfulness, and various other kinds of interventions for helping with their depression. Keshav wouldn't have had time to cover that because it's quite a lot to cover. And second thing about the second talk, Dr. Santosh mentioned it in passing, but I think one of the things to do is to approach Alzheimer associations in different parts of the country. Almost every state has an Alzheimer chapter, so it's good to approach. So a group support model is also something that is useful, especially for family members and also in the early stages in people who have dementia. Thank you. I think both of them did an extensive presentation, so thank you very much, both of you.
I think Dr. Santosh sir just joined. I think some connection break was there. Yes, sir. You can unmute, sir, yourself. Yes, sir.
Okay.
There are no further questions, sir. Actually, there is a comment from Matthew, sir, about suggestion from Matthew, sir, about the individual interventions, apart from the cognitive intervention for people with patients with dementia and caregivers. So, any more comments from you, sir? I think there are no more comments, sir, from the chat box. I have seen both in YouTube also and Zoom also. I think people ask about the module which sir has mentioned. Apart from that, there are no questions actually. I think, but what sir mentioned, the iSupport program is a very useful program actually for the clinicians themselves to read actually the components. I think it is a very good program for the caregivers actually. If they could go through now the program online is not there, but they can actually go through the articles which the sir has mentioned, the components of it. Sir, Santosh sir and Keshav sir, shall we wind up, sir? We will.
Sure. Sure.
Okay. I thank all the participants for their patient listening and also for the queries and active listening. Thank you. And meet you next week on same time. Yes, sir.